Give me your card.
Actually, I've sent you a couple. I don't want to mess with that anymore.
Well, how am I going to find
So close to retirement, I don't want any more.
Which we heard about last night.
Yeah, lawsuit. Well,
It wasn't one.
No, I was surprised. It's
oh, it's fabulous. It's the best.
They have no
Four
use.
times. Here you go.
And
You still kids for the COVID?
Put
No.
yours in this in my
got hurt kind of on the disabled list, probably permanently now. But you know, the community where they're from is small, so it would be hard for them. They're very prominent in the community.
That's not
That's what I tell everybody. It's another issue. And I actually think that kids played on fields together, like softball teams.
So this didn't happen in Phillies, within small towns.
But then Gary eventually moved to Pennsylvania. He had a child.
Get together there several years ago.
So is he definitely out of baseball? Is that right?
That's my understanding.
Good.
Just a couple of years. It was like 2 or 3 years ago.
Yeah.
Excellent. He had these huge contracts.
Yeah. He lives in Arkansas.
He loves it there.
Oh, and I believe it. You know, wherever you live is great. You know, you get chauvinistic, right? Everybody's chauvinistic about the area they live, and they think that it's the coolest place to live. And they think, why would anybody live there? They're obviously very beautiful, neat places, and the most important thing is family and friends, and that trumps everything. I did my residency in Salt Lake City. All the people came in, Texas, etc. And they all complained about where they live. Guess what? Like the training program, go back to West. I went to UW here. I went to UW. Good skiing though when I was in Salt Lake. Yeah.
That's where Chuck lives now.
Yeah, he's Mormon, and so obviously Latter-day Saints. Well, actually, Salt Lake City is 50-50. The rest of the state's about 80 to 90%. No, it's a beautiful state, and I enjoyed the 4 years I was there. Both my kids were born there. That was in the 70s, so it's beautiful. I haven't skied there though in 10, 15 years. I have a place to stay with my brother-in-law in Colorado. So
How long was the run? 42 hours?
yeah, 2.5. 2.5. That's 1,000 miles. I found in Colorado Springs a little airport there. And compared to Denver, which is huge, you know, it's a different hassle. No line. Family. It's about 9. It's about 2 hours drive. It's here. Denver is probably a little. Well, I hope so. You know, it's kind of like
New York Times.
But you know what? People skiing in their 80s now. When I started skiing as a kid, you know, I lived here. I lived in the nobody's 60. Now, you go to Sun Valley. You feel young. That's funny. As long as you keep up in reasonable shape and you keep doing it. It's not a challenge to pick up at 60. You fall, you hit, you know, you bounce. So you don't want to do much of that. So you start young so you can ski well. And if you can ski well, avoid collisions, you can ski in your age.
Collisions with people in
Trees is the biggest one people have. People do hit a tree or something. You know, a lot of times you know, with these new technology, you got their ski lift ticket, you can find out how fast. That'll be vertical speed over the horizontal. But you're skiing 35, 40 miles an hour. So if you hit a tree at 35, 40 miles an hour, yeah. Used to got skis. I done my life without a helmet. Now it's interesting. Helmets have come out. Everybody wears a helmet, and that should help a little bit. Usually, this try to kill yourself.
I should get a quick cup of coffee.
Yeah. Oh, the coffee can, huh?
Let our guests get a cup of coffee.
He has to learn to fight for himself.
It's the Seattle way.
I think it's everywhere.
I'm hungry again. Not all of us got food.
We had a deal going
One got steak and one got salmon.
Oh, yeah. I was right near there.
They're both happy.
Well, you know, that's a decent size lake.
You feed each other.
Yeah. No, I don't. You know, I know when I was different. When I was a kid, but without making caffeine. But we only did it twice. But no, the area of the state. You know, I remember that guy was hiding out and they finally saw him.
Yeah, I was in that area just before that happened. Just before that happened. I remember the small town where he was from. I drove through it. It's incredible.
That was a few years ago. How long was it?
About 2 years ago. Yeah.
I wasn't on that.
Tell us.
Tan. Why are you tan?
Oh, you just happened to be in Hawaii.
Oh,
I might tan. I put on sunscreen every day.
you tan.
Well, vitamin D.
Yeah.
Good to call that.
No, I take vitamin D in a little pill.
Mike, did you make any meetings? Or just down the golf course?
I went to all of these.
Did you?
Yeah. They hadn't timed right, you know. So.
Yeah, they give you half days, don't they? That's the beauty of that meeting.
No.
Right, didn't realize? Was that snows in the Grand Canyon in the winter?
Mary, do you get
There's a blizzard through there right now.
from your kids? Parking tickets from your kids?
No. No,
I'm not even sure what this ticket is, and I hate the guy.
Just the convertible.
So I sent it to her. I can't tell what these numbers mean, but it's like, and there's options of these different fines she has to pay.
With the roof down.
I don't know what it is.
Wait,
Parking ticket,
proof of correction, pay the bill.
different options, pay 200 or,
Due for court admission. Or she can go fight it and then she probably gets her money
I
back.
don't even know, it doesn't even say what the infraction is. I can't tell what the,
It's expensive, $238.
those are the codes and it doesn't say what they,
Disposal works.
number.
It worked.
May I have that?
The first day, you know, we ran the dishwasher and all that.
Yeah,
Matt taught it to school in 26.
yeah.
Like,
And it was,
that might work.
I don't know.
I still got
Yeah,
all your
I
putty.
sent it
You're not planning on doing anything right away with the tube. You left all that stuff there just in case.
Can't tell.
I'll bring it back.
Oh, not in California, but here in Washington.
I'll let you know if I need one.
What's her name?
It's,
Jeannie Mucklestone?
Oh, I see what you mean, yeah, occasionally.
I've only used them twice.
Yeah, put a new guts inside it, yeah. I did that upstairs, the upstairs bathroom, about 5 years ago. Well, if you have expertise in that, you're
I know. Right.
charged down.
I'll take it.
I know.
He's in Bellevue. He's right off the Expressway. No, it's a good guy.
Good. Very nice.
The word of the day is Cincinnati.
It said you had an incredible wedding. Did you go somewhere? Oh, you did? Where'd you go?
All right, let's get settled and go ahead and get started. I think our technology is working well today. I want to thank Dave Skoner from coming out from Pittsburgh to be our speaker. I know from being at dinner with him last night, he had he had to change his flight plans because of snow in Denver, so much appreciated he took the extra effort to get here. We're going to talk about immunotherapy and the management of adults and children with allergic conjunctivitis. Previously, this was titled SLIT, so I assume there's a fair amount of emphasis on our new sublingual immunotherapy. Dave, thanks again.
I'd like to express my appreciation for being invited here. Len, thanks for inviting me, and appreciate all the support in coming here as well. And I did decide to gear this toward sublingual immunotherapy. We're very accustomed in our practices to using subcutaneous, and the question is this new thing on the block, where is it going to fit in? Sublingual therapy. And I think if we had a large room filled with our colleagues from around the country, they would be divided over where it fits. Some welcome it as a new mode of therapy to offer to their patients, maybe a new way to bring patients into the practice. Others feel very threatened by it because they mainly use allergy shots, subcutaneous, and they feel that may cut into that business a little bit. So the specialty's somewhat divided over where sublingual therapy will fit into what we currently do. But my goal today was to get you to understand what this therapy is about, and to do that, you have to really delve into the details of the clinical trials. If you understand those, you can understand where this could fit into your practices, and I personally don't believe you'll view it as a threat if you currently do. So these are my disclosures, and I've worked with companies that make these products, such as Greer, or market them, such as Merck. And my goal is to identify pitfalls in the use of SLIT tablets. SLIT drops, sublingual immunotherapy drops, are off-label. We're not going to talk much about those. They're not approved by the FDA. The tablets are approved, and that's why they deserve discussion in a forum like this. But I want to talk about some of the pitfalls and solutions to those pitfalls here in the United States, related to efficacy, safety, and awareness. Now, SLIT has been used for many, many years in Europe, and just 5 years ago, I used to sit with Giovanni Passalacqua from Genoa in a session at the Quad AI, and he'd be talking about all of his experience, and I have no experience to talk about. And we used to treat this as sort of maybe like voodoo or witchcraft. They're using that stuff over there, and we don't use it here, and we don't think it even works. But now there's strong supportive data, and I'm going to review some of that with you here today. So the first pitfall that I see is if we have the belief that SLIT tablets lack efficacy, or that they have efficacy only in monosensitized patients. As you know, most of our patients are polysensitized. How can you treat with a single allergen? And the other pitfall is the belief that they have no disease-modifying effect. We would believe that at least subcutaneous immunotherapy has a disease-modifying effect. Maybe SLIT tablets do as well. Of course, maybe they don't, but some of the evidence says that they do. So let's deal with these. pitfalls, but in order to do that, I think it's important for you to have an understanding of trial design. How are slit trials designed, and what are some of the variables in a slit trial? These are done during like a pollen season. So sometimes pollen seasons are really good and strong and they produce a lot of symptoms that you could impact by a treatment. And sometimes pollen seasons are feeble and you don't see much pollen counts, you don't get much symptoms. Very hard to show any benefits of any kind of treatment. And there's also, of course, subject-related variables too. Their sensitization status. What drives their symptoms? Is it one allergen? Is it two allergens? Is it more? So in order to review these clinical trial factors and variables, I decided to pull this paper from published by Steve Durham from the UK. And the title of this, of course, is Magnitude of Efficacy Measurements in Grass Allergy Immunotherapy Trials is dependent on how much pollen you're exposed to. And we really didn't think much about this until these slit trials were so very carefully done in the United States and in Europe. So if we look at the typical pharmacotherapy trial on the right, people are generally enrolled during the pollen season when they're symptomatic. And you look at reductions in symptoms, let's say from a nasal steroid spray. And the treatment period for the pharmacotherapy trials is typically like 14 days or so. And they're scored symptoms during that 14 days, active drug versus placebo. And because it's a short trial, rescue medication is not allowed. It's just like intranasal steroid versus a placebo for 2 weeks. And the primary objective is treating those symptoms. Well, immunotherapy trials, by definition, have to be a little bit different. You have to start the treatment before the season starts, like 2 to 4 months, when patients are asymptomatic. And the treatment period is often like a whole year. It could be 5 years because it's immunotherapy. And the symptoms, instead of being scored only like during a 2-week window in the peak of the season, they're scored for the entire pollen season. So sometimes you have good days in the pollen season, sometimes you have bad pollen days. And everything can vary, including the symptoms during the season. The endpoints are looked at as differences in the means over the whole season, instead of a change from baseline in the pharmacotherapy trials. And in immunotherapy trials, because they're so long and people are on a placebo and some of them are suffering extensively, rescue medications are allowed. They're allowed in these trials, so you have to take them into consideration. And of course, in these trials, the primary objective is not treatment of symptoms, but prevention of them from developing in the first place. So there's some fundamental differences, and we're accustomed to thinking about and designing these trials on the right. The ones on the left took a lot of thought, international leaders, to develop the trials. Here's the typical immunotherapy trial you see here. And the entire pollen season is this light-shaded area. The peak pollen season is this is grass pollen here. The peak would be this period right here. The treatment for this immunotherapy trial would start 2 to 4 months before this season would start. And the duration of treatment would be the entire pollen season and before the season. So it's called pre- and co-seasonal therapy. And there's ways to define the start of the season and ways to define the peak of the season as well. So here's a very interesting graph looking at pollen counts on the horizontal axis, the percent of days with those pollen counts. And if we look at those, these are low pollen counts here. There's a lot of days during a season when there's low pollen counts. When you look at the days with high pollen counts, there's relatively few days with those, but they're there. If we look at the predicted combined symptom and medication scores, so when you do these trials, you have to take into account symptoms and medications. you combine them into a score. These are rescue medications. If you look at the placebo group, which is this one, and the grass pollen slit tablet treatment groups, which is this one, you can see on days with low pollen counts, both groups are relatively have low symptoms, and there's very small differences between active treatment and placebo, as you see here. But if you look at days when there's high pollen counts out here, you can see there's more symptoms in general in both groups, but the level of efficacy, the difference between the groups, is much higher. So the magnitude of efficacy is highly dependent on how much pollen exposure there is on a day and in a given year, wherever you choose to do such a study. And what Steve did is he plotted all the various trials that have been done with the grass tablets and looked at the percent reduction of total combined score relative to placebo. And these are escalating pollen counts during the first 20 days of the season. And you can see a nice direct correlation between these two variables across multiple trials. So finding efficacy in these trials, strong efficacy, is really dependent on what a natural pollen season delivers to you when you choose to do your study. And you can't always, as you know, control that.
Looks like the North American studies are much less efficacious than the European ones if you separate the red from the blue.
Yeah, the North American being here.
All over the map.
Yeah. And a lot of that relates to pollen counts. Pollen counts were generally lower in the North American trials than they were in the European trials. Yeah. So the magnitude of the treatment effect compared to placebo is highly dependent on pollen counts. This relationship has to be considered when we interpret clinical trial results. And the same is true when we compare efficacy estimates from different trials in meta-analyses. So when these trials were done in the U.S., and they're called pivotal trials, pharmaceutical company has to sponsor them, the FDA has to condone them, and the design was critical. You had to get it right. And there was a lot of experience in Europe that guided how this was done. And I mentioned that there's relief medications available to patients in a trial. So you have patients developing symptoms or not on active treatment or placebo, and some of them are taking daily medications for relief and some aren't. So what you have to do in these trials is take your daily symptom score, add in your daily medication score, which is relief medications, and you get a total combined score. And it's been agreed upon in Europe and the United States, this is the way to analyze a trial, is to get a total combined score. Then the question is, do you analyze for the entire pollen season, or do you focus on the peak when people's symptoms are at their worst? And I can tell you, in the beginning, it was all focused on the entire, and then as the companies got more courageous and they designed primary endpoints right around the peak. You could imagine you could fail there too, because the symptoms are so bad during the peak of the season. But if that's where you wanted a medication to perform, that's the ideal spot to be in. So the scoring systems that were used were not developed lightly either. You can see there are 6 symptoms that are scored: nasal and eye symptoms, 0, no symptoms, to 3 for severe. So you could have a maximum daily medication score of 18 if every symptom scored at a 3. The medication score on the bottom maxed out at 36, and every treatment that was used was weighted, as you see, with the highest weight given to the need to use an oral corticosteroid on that day. These weren't all thrown at the patient at one time either. They were offered these in sequence. If they were really symptomatic, they first got the oral antihistamine. They needed more ocular antihistamine. They needed more intranasal steroid, and if they needed even more, then the oral prednisone. Now, when we interpret clinical trials, we're accustomed to looking at mean values and comparing those means and coming up with a p-value for statistical significance. The FDA chose not to view these trials that way. They didn't look at p-values at all. They looked instead at mean values and 95% confidence intervals. And the analysis was based on the way they analyzed vaccination or vaccine trials. They considered this a vaccine, basically, for analysis. And so they came up with this term called clinical relevance. Clinical relevance. Based on the total combined score, that sum of those two scores. And in order to be clinically relevant, the data had to satisfy two endpoints that you see up there. First of all, the average difference had to be less than or equal to minus 15. So if you had a minus 15, it was good. If you had a minus 20% difference, it was better. If it was minus 25, it was even better. So very big differences is what they wanted. The other thing they wanted was an upper bound of the 95% confidence interval that was less than or equal to minus 10. So in worst case scenario, 95% time you're in that interval. The worst case scenario is you could be at a real difference of minus 10. So they were very careful not to let that upper bound get near zero, because there would be a small chance that your actual difference was zero then. So here's some examples of that. Example number 1 here. The total combined score, percent difference active versus placebo, is minus 29.6. This is the lower bound of the 95%, upper bound. So there's a 95% chance that the actual value, which is this is what they measured, but 95% chance that the actual value is between these two numbers right here. And this clearly satisfies the FDA criteria, which was less than or equal to minus 10 for this, and less than or equal to minus 15 for this. Number 2 also does it, but with a broader interval here. You can see the 95% confidence interval here is extending up a little bit closer to minus 10, but didn't go above that. So this satisfied that criteria. This one here, example number 3, the mean difference satisfied the FDA for clinical relevance, but the upper bound did not. Here you can see there's still a small chance that the actual difference could be minus 5.8%, and they didn't want that. They didn't want to have that chance. Wanted everything to be less than or equal to minus 10. And number 4 failed because it failed to have the big enough difference between the active and the placebo treatment groups. So these are very strict criteria. It's a high bar to hit, higher than a p-value. And I'll show you an example of that here in a moment. So this was the large study that Steve Durham did to look at disease-modifying effects of sublingual immunotherapy. 634 subjects randomized to grass immunotherapy or placebo for 3 years, continuous solid treatment for 3 years, and then they stopped treatment and followed them for 2 post-treatment years with the blinding maintained. And these were all grass pollen allergic patients. They started treatment about 4 to 8 months before the first season, and they all had access to relief medications. So here's the results of Steve's trial. You can see in year number 1, the difference was minus 34.2%. That's a big difference. The upper bound of the 95% confidence interval was minus 26.3, clearly satisfied the high bar that the FDA set. The same was true for treatment year number 2 and treatment year number 3. Then treatment was stopped at the dotted line, and you can see the first follow-up year. The difference still met the FDA criteria, minus 27.2%. The upper bound did too. It was minus 12.4%. So you treat for 3 years, you stop, and you get 1 additional year of benefit. So 4 years of benefit out of 3 years of treatment. So if you remember from the previous slide, there was a second post-treatment year. It's not up here. The reason it's not up here is that it did not satisfy the FDA's criteria, that high bar that I told you about. But this is what Steve published in the manuscript. And the data for Season 1, Season 2, and Season 3 are what I just showed you. And I also showed you the follow-up Season number 1. I didn't show you follow-up Season number 2, which didn't meet the FDA's criteria, but you can see that there was clearly, in that follow-up Season number 2, there was clearly benefit there, and it was statistically significant. But it did not meet the FDA's criteria, so it didn't make it into the label for the medication. Now, there were also immunologic benefits, as you would imagine, from the treatment in Steve's trial. This on the left is the change in IgE blocking factor, and the graph on the right is the change in specific IgG4. And you can see clear immunologic differences in the grass immunotherapy versus placebo groups. And you can see that those immunologic benefits persisted during the post-treatment years. So this provided some evidence that there is disease modification with sublingual tablets.
Are those different? What's IgG blocking factor? It's not IgG4.
Right, it was just a factor that blocked IgE.
So is he implying it's something different than IgG subclass 4? Yes.
Yeah. So that was 3 years continuous dosing. What about just pre- and post-seasonal dosing, 1 season? And that's what was done in the pediatric trials. And I actually co-authored this with Mike Blaze. And these children started treatment 16 weeks before grass pollen season and then continued the treatment during a pollen season. You can see fairly large numbers in the trials, 175 and 169. They were 5 to 17. They were Timothy grass allergic. And they started treatment again 16 weeks before. And they all had injectable epinephrine at home, sitting on the table, in case they developed itching under the tongue that seemed to be spreading to a feeling of swelling under the tongue and an anxious parent overlooking their shoulder. There were a lot of moments when you really didn't know what to do because slit tablets were really new to us. And in the initial clinical trials that were done with this, there were a few moments that nobody really knew what to do because there were reactions were developing and they had the EpiPen there. Nobody knew quite what to do, but in the end, the safety looked pretty good, and I'll tell you about that in a moment. Everybody in these trials was Timothy grass allergic, but one of the exclusion criteria can tell you how you can find patients like this in your practices. As you know, just about everybody is polysensitized. People that respond to these tablets are not polyallergic, they're almost monoallergic. And by that I mean what's responsible out of those polysensitizations, which allergens are mainly responsible for their symptoms? And if it's mainly grass pollen driven symptoms, even though they're polysensitized, they often can respond to these tablets. So what they did is they excluded patients that had sensitizations to like tree pollen or to dust mite, and they had symptoms from those allergens. If they did, they were excluded. They tried to purify a population that was polysensitized but monoallergic to grass pollen in these trials. And that's who you would look for in your practice. Now, you'll say, I know you would, I don't have monosensitized patients, and none of us does. We all have polysensitized patients. In allergy immunology practices, you're probably getting patients, though, that are polyallergic, too. They're having symptoms from dust mite and ragweed pollen and grass pollen. I think many of these monoallergic patients exist in primary care. I don't think they come in to see allergists as much as pharmaceutical companies would like to think that they do. There's some other exclusion criteria up there as well. Persistent severe asthma, severe atopic dermatitis, chronic urticaria and angioedema, and so on. So in the pediatric trial, most of them were boys. There's a nice distribution of the age ranges up there from 5 to 11 and 12 to 18. And you can see about a quarter of the children had asthma. And it was all mild asthma. There were no severe asthma in these trials. And the sensitization status is shown up here. Overall, about 90% of the children were polysensitized. Yet they were treated with a single allergen under the tongue. Tree pollens, weed pollens, cats and dogs, and dust mites, and molds in that order. Here's the result in the pediatric trial. And I would venture to tell you, and I think you'd probably agree, that trials in children are harder to conduct than they are in adults. And it's harder to show benefit in children, especially like a 5-year-old, where the parent is observing them, getting secondhand information on whether something's helping or not. It's very hard to show efficacy in pediatric trials, but there it is. It was shown. The difference in the total combined score was minus 26%, and the upper bound of the 95% confidence interval just made it. It was minus 10.1. If it had been minus 9.9, the FDA would have said it didn't work in children. So it just made it. The trial also showed some impact on quality of life for the entire season and the peak of the season. This is rhinoconjunctivitis quality of life questionnaire. So that's a walkthrough of the grass sublingual tablet. And the only other one that we have the ability to treat now is ragweed. So Hendrick Nolte put together this trial that enrolled over 300 subjects. Started ragweed sublingual immunotherapy or placebo about 12 weeks before the start of the ragweed pollen season, and then continued it right through the season. So this is pre- and co-seasonal treatment as well. And they also received symptom relieving medications if they needed them, and had epinephrine as well. The patients in the ragweed trials were also polysensitized. Go and try to find monosensitized patients. It's pretty hard to do that. The polysensitization is listed up there. Most commonly tree and grass and mold and so on. So, as I mentioned earlier, you can choose to analyze the entire season, which is on the right. The entire pollen season effect was minus 26% reduction. The upper bound was minus 13.5. And then they focused in on the peak of the pollen season, about a 2-week period of time, when people are at their worst. And you can see the therapy still performed there. It still worked. And the FDA said, it meets our criteria for clinical relevance. Now, Hal Nelson decided to look at this a different way. He took the grass pollen immunotherapy trials, the sublingual trials, and combined the trials and looked at, over 1,800 subjects here from 6 different double-blind placebo-controlled trials. And here's the overall effects in those trials. It was minus 27% reduction with a highly significant p-value. And then he identified the subpopulation that was monosensitized. They were sensitive only to grass pollen. And you can see that difference is very similar to the overall difference. And then he also looked at those that were polysensitized get treated with only grass immunotherapy. And the bottom line is the differences were all pretty much the same and highly significant, whether you were monosensitized or polysensitized. So the differences that we were looking at there, minus 25 to minus 30%, perhaps. How does that compare with the medications that we use? We're talking about, especially in children, let's say pre- and co-seasonal therapy. It's almost the way we would use a medication, right? With subcutaneous immunotherapy, it's much longer than a pre- and co-seasonal period. So how does it compare? Well, antihistamines usually produce effect sizes of about 8%. Leukotriene antagonists a little bit less than that, about 5%, and corticosteroids in the trials about 15%. So the effect sizes are generally bigger with the SLIT trials than they are with the medication trials. So the next...
It's amazing to me how poor those numbers are. If you told me you're going to prescribe an expensive medicine and I'll get 5% better, I'd say forget it. Don't usually think of it that way when you do everyday clinical practice.
I know. And they're all over the counter, so we're not even prescribing them anymore. People are self-diagnosing and self-treating with those expensive medications too.
Are you going to come to a comparison of those kinds of percentages with subcutaneous and SLIT?
A little bit toward the end.
Yeah.
I just wanted to review a little bit of evidence. We talked about disease modification earlier, but can we intercept or interrupt the allergic march? Go from being sensitized to one allergen to 2 to 3. Can we stop the progressive sensitization march? And can we also prevent the progression from allergic rhinitis to asthma in patients? Well, there's data, but there's not a lot of strong data. And what I'm going to show you here was based on SLIT drops, not tablets, SLIT drops, which are not approved by the FDA here in the United States. And here it showed that SLIT drops reduced the development of asthma in children that had allergic rhinoconjunctivitis. These were 113 children, 5 to 14, with grass pollen-induced rhinoconjunctivitis, and they received 3 years of co-seasonal SLIT by the drop method. And at the end of that, you can see the development of asthma. If you look at SLIT, asthma, and no asthma, and the control group, asthma and no asthma, the development of asthma after 3 years was 3.8 times more frequent in the controls compared to the active SLIT. So this suggested that SLIT therapy could interrupt that part of the allergic march. And this was a 10-year-long study of SLIT drop immunotherapy. These were 60 children, 3 to 17, with house dust mite-induced rhinitis, with or without mild to moderate asthma. And they received SLIT drops under the tongue for 4 to 5 years. And here we look at the percentage of children without asthma in the SLIT-treated group. At baseline, 42% were without asthma. At the end of the 4 to 5 years of treatment, it was 88.6 were without asthma. And in a 10-year follow-up, it was 91.4% without asthma. And if we look at the end of treatment here, SLIT, you can see a lot with no asthma here. Compared to the controls, very little without asthma. So this was supportive of that concept as well. And then this is another SLIT drop treatment showing that this therapy could prevent the development of new allergies in adults. There were 78 of them here, 18 to 65. House dust mite-induced rhinitis with or without asthma, and they received SLIT drops for 3 or 4 or 5 years. And they looked at the percentage of patients with at least one new skin sensitization at the end of the study. And in the control population that didn't receive SLIT, 100% of them had developed additional sensitizations. For SLIT after 3 years, you can see it was 21.4%. The group that received it for 4 years, it was 12.5%, and the group that received it for 5 years, 11.7% developed new allergies. So this suggested that we could reduce the development of new sensitizations with SLIT therapy. So the pitfall that we mentioned in the beginning, what's the solution to these pitfalls? Well, in North American clinical trials, the tablets passed very rigorous statistical tests and produced clinically relevant benefits under difficult circumstances. And the European trial that I showed you showed a disease-modifying effect. We should select patients for these therapies appropriately based on symptom severity. It was moderate to severe in the clinical trials. Then we can consider GRAS tablet sublingual immunotherapy as possible first-line therapy when GRAS is the dominant clinically relevant allergen, that sort of monoallergic patient among all those polysensitized people. That patient could be monosensitized to GRAS or polysensitized, including GRAS. We could also consider this tablet as second-line therapy in polysensitized patients who are polyallergic, but they don't want our shots. The shots are too painful, too inconvenient, and maybe in those patients, some immunotherapy is better than none. This might be where it might be more likely used in our practices. And then I think we need more trials comparing SLIT to medications to make any more conclusions. The next pitfall could be underestimating side effects and risks. And the good news is that there's now, across the world, there's standard grading of the adverse events that occur in SLIT trials. And in the pediatric trial that I showed you, you can see that about 1/3 of patients that put this under their tongue feel itching in the throat or under the tongue, sometimes itching in the ears, and so on. And you can see some lip swelling on the bottom there. Mouth edema, a feeling of swelling in the mouth, occurs about 10% of the time. Most of these reactions are mild to moderate. They usually don't cause discontinuation. They usually occur the first day in the office when we're watching them. They usually last a week. And if they don't, if they're lasting 10 days, 14 days, that patient should probably be stopped with that therapy. There's no worsening of asthma noted in the trials. And a small discontinuation rate there. You can see 13 on GRAS SLIT and 5 on placebo discontinued, and that's pretty low. We, since some of the patients in the trials had asthma and some didn't, we looked at whether there were more adverse events in the asthmatics versus the non-asthmatics when they received placebo or GRAS sublingual immunotherapy. And bottom line was asthma didn't influence the reporting of adverse events, and there was really no worsening of mild asthma from the treatment either. In adult trials, there were 7 out of 1,669, 0.4%, that had treatment-related systemic allergic reactions. 5 of the 7 had it on day 1 when they would be in our office under observation. 1 had also a reaction on day 2, and then 3 of the 5 received epinephrine, and of the other 2, 1 reacted on day 2 and another on day 42. That's why we give epinephrine to have at home, because these can happen later, but it's more common to happen in the first day in the office. 1 child experienced a treatment-related systemic reaction and was treated with epinephrine in the pediatric trial. So you can see 0.2%, 0.4%.
What kind of symptoms are you talking about?
Throat swelling, mainly. Stridor, difficulty breathing. So, in terms of this pitfall, I think we need to inform patients about the local side effects that can develop, frequency, severity, and duration of those. Children should be administered under adult supervision when they're going to be home for a little while after getting it. And we should not give the therapy to patients with severe, unstable, uncontrolled asthma. Haven't been studied. Observe the patient in the office after the first dose for 30 minutes, because that's when the bad reactions most commonly would happen. And then for those reactions that happen at home, prescribe epinephrine. Yeah.
Since your therapy is sublingual, how can you be sure that the throat swelling isn't a local reaction instead of a systemic one?
You can't.
So is this just their best guess?
Yeah. Yep. That's all you can do.
I can make the statement if the local symptoms continue beyond a week, they should be stopped.
Because in the trials where there were systemics later on, those patients struggled in the beginning. Usually these symptoms the adverse events are mild to moderate, and by the time the first week is over, they're gone. They don't have them anymore at all. The ones in whom those local reactions persisted out to 10 and 14 and 21 days, they're the ones that develop the systemic reactions later on. So the recommendation is if these don't go away in the first week, think about stopping the therapy so you can avoid some of the reactions later on.
Do you have patients?
When the first trials were coming out, they were having some case reports of EOE. Has that, what's happened since it's been in the real world?
Well, in the clinical trials, the large clinical trials, there were none. When the label was being negotiated with the FDA, there was a report in Jackie, in the literature, some patients who were on sublingual, and I think they were drops, developed EOE. So EOE ended up being very prominent in the label. I don't think I have it as part of this presentation, but if patients develop symptoms of EOE while they're on SLIT should be stopped, is what's in the label. And if patients have that history of EOE, they should not get on SLIT therapy. But no one's proven definitively a relationship that patients on it have developed it. So there's all kind of cautionary statements in the label.
What about having patients use antihistamines for the first week or two while they're taking their SLIT? Do you have them do that?
You can. It might mask. I told you these adverse events are usually mild to moderate. They peak on the first day you give it when you see them in the office, and they go away over time. Mm-hmm. You may mask that process or mask the more severe patient. So I don't routinely do that. It wasn't done in the clinical trials either. But I know some of our colleagues do it and would do it around the country. I have no problem with it. But it's not in the label or anything like that to do it. That's up to us.
Are the drops licensed in European countries?
I think so.
And are they similar potency?
I'm not sure.
They're not being considered in the U.S.
Not that I'm aware of, no. I think it will be hard to do that because the temptation there, most of the drop therapy is multi-allergen. Right. And coming up with combinations to get approved. I got this combination of grass and ragweed in the drop. What are the criteria that you need to satisfy to get approval for a combination drop therapy? Or for that matter, a tablet that had both allergens in it. We don't even know, there's no precedent for that at the FDA. As you know, when combination therapy at the FDA was considered for other purposes like asthma, combination therapy for inhalers, the combination had to be proven to work better than either therapy alone. I don't know what the FDA's would choose as the criteria to meet for combination therapy with SLIT tablets or SLIT drops. And you can imagine all the multiple different combinations as well. It's almost mind-boggling. So earlier on, I implied that a lot of the patients that are eligible for this therapy exist in primary care. They might not be coming in to see us because I think we see polysensitized, polyallergic people the polysensitized monoallergic patients might bear it out in primary care. So what do primary care docs and patients know about this therapy? And I think there's a market here for allergists. If you want to find patients that need this form of immunotherapy, I think developing relationships with primary care docs probably would be a good thing to do. And we published these survey results. And this is a provider survey. And this tested the provider beliefs that allergen immunotherapy can cure allergies. And of course, when the allergist was asked that question, 70% agreed with that statement. And for subcutaneous, for sublingual, it was a much lower percent among the allergists. But if you look at all the primary care physicians here, and in particular pediatrics, there's a lot less knowledge about the benefits of immunotherapy compared to what the allergy community knows. So there's a lot of education needed in primary care. And this tested patient knowledge of attributes of immunotherapy among those that had ever heard of immunotherapy. They had already heard of it. And the one I have boxed here is immunotherapy can cure allergy symptoms. And you can see the distribution here of agreement to disagreement is all across the board. Patients could be more educated about the benefits of allergen immunotherapy as well. So if we overestimate that, we will miss the mark, because I think we need to recognize that primary care physicians and patients don't really fully understand immunotherapy, and we can seize the moment to educate them about it and tell them that there's an option out there that can be without shots and convenient given at home. The next pitfall would be that drops are synonymous with tablets. Just putting an allergen under the tongue, it's a drop, it's a tablet. But the reality is that the drops haven't been nearly as well studied as the tablets have been. And there's one exception to that, and that's this study. It was called the Ragweed Sale Study, Sublingual Allergen Immunotherapy Liquid. And Peter Kretikos designed and published this trial, and this was ragweed season. You can see the pollen season displayed up there, and you can see the nice separation between the liquid and the drops under the, or placebo drops under the tongue. So this is a good example of liquid immunotherapy, but to my knowledge, this is not being pursued as an FDA indication, to my knowledge, as a drop. So the SLIT tablets have undergone extensive testing in pivotal trials, and they're FDA approved. Aside from that trial that I just showed you, there's very little data to support the use of SLIT drops. So I don't know if our colleagues are using drops. I know a lot of otolaryngologists use drops under the tongue, but there's no FDA approval for them. And of course, I like using FDA-approved treatments when possible. Okay, we discussed for a moment SCIT versus SLIT, and there's another pitfall here in the assumption that SCIT is always more effective than SLIT. Is it? Is it always more effective? Well, this paper was published last year, and it was a review. And there were two ways to look at this. One was compare SLIT and SCIT indirectly. So here they took trials where SCIT was compared to placebo, and in separate trials, SLIT was compared to placebo. And that was done in 2 review articles. So you look at both of their effects relative to placebo and see if one looks better than the other. But they're not head-to-head. The other way to look at it is in head-to-head trials, and those are shown on the right here. And compared to the number of trials over here in the indirect analysis, you can see there's relatively few head-to-head trials over here, 8 in this one and 3 in this one in the pediatric world. And symptom scoring favored SCIT in this direct analysis. It also favored SCIT here, but with low-grade evidence. It was moderate-grade evidence here.
As far as, and that was for symptom score. For medication score, there was low-grade evidence where there was no difference in effectiveness between SCIT and SLIT for medication score. And here it was low-grade evidence favoring SCIT. So overall, you might say, well, SCIT's favored a little bit more than SLIT here. But if you look down at the safety, there were generally more reactions. Here's anaphylactic episodes, 1 SCIT, 0 SLIT. And over here, in this one, the same thing. Systemic reactions, 4 versus 0, and so on. So they attempted to do what we wanted to know earlier, but it's difficult because there's so very few head-to-head trials. So the Practol consensus report concluded that there is insufficient evidence to do a meaningful comparison of efficacy between SCIT and SLIT. However, existing evidence suggests both routes are effective in reducing symptom scores of medication use in patients with allergic rhinitis and asthma compared to placebo. So we're desperately in need of head-to-head trials to help sort this out for us. So in conclusion, there are many SLIT pitfalls that I tried to identify with you related to efficacy, safety, and awareness. I think each pitfall has a solution, but some require paradigm shifts for us. And I just wanted to finish by mentioning the Nemacolin Asthma Conference, and I know Bill has lectured there in the past, and we're now in our 11th year, and the conference is surviving, it's thriving. Paul O'Byrne became one of the conference directors, and it's around trick-or-treat weekend every year at a resort in southwestern Pennsylvania. If you get a chance, it's 3 great days of asthma discussion. One of the, since Bill was there, one of the attendees said it was like being courtside at an NBA basketball game. The NBA basketball players of the asthma world come there in a small medical school auditorium room, and people kind of duke it out, and everybody gets to watch the fight go on. So it's kind of a fun atmosphere. So
Bill have a good 3-point shot?
He was right on 75% that day. So that's pretty much what I wanted to cover with you. Yeah.
What's the rationale for stopping for 6 months on the oral immunotherapy versus just keeping them on a low dose?
Compliance.
You mean the tablets?
Yeah. So when you do it for 6 months and stop for 6 months, I mean, it's just, you'd think there may be some benefit to just extending the course out continuously. So, but I don't see that in the papers anywhere.
Well, at least for the grass tablets, the FDA approved 2 different dosing methods. One is the pre- and co-seasonal dosing. It started 16 weeks before or so and then continued through the season. And there you would spend 6 months off, so it might cost you less. Your immune modifying effects may not be as strong that way. The other way, though, that they approved it was the 3 years continuous, and with 1 additional year of benefit. As allergist immunologists and our familiarity with SCIT, that would be probably the preferred method, is to go on this for 3 years solid. But that increases the expense a little bit, and it raises probably more issues about compliance. Europeans have great difficulty with compliance with sublingual tablets. And I think we have, and we will here as well. I mean, think about, I live in the Northeast, and we get snow on the ground in January. In January is when we have to start this therapy. People have no symptoms from their grass pollen yet. There's snow on the ground outside. They don't want to go out of the house. And we tell them they have to come in and get the first dose of this under their tongue in January outside of the season. That's a real paradigm shift. Maybe we would avoid that by the continuous as well. They don't have to come in every January to start their dosing up in the office.
When we tried to negotiate with insurance, it seems like they only have the 6 month on, 6 month off option. They don't even allow you to do the contingent part. From my limited trials of fighting with them.
We haven't had that problem. I just started a guy yesterday, and I started maybe 10 recently, and just told him, you can do it this way, you can do it this way. And maybe I've jumped ahead. I've sort of assumed if you just do pre-seasonal and co-seasonal, I tell them there won't be any disease, I don't use the term disease modifying, but you won't have any long-term benefit after you stop. the advantage to doing it year-round, and if you do 3 years, you'll have benefit that'll continue a year or two beyond. But I haven't had anybody tell me they couldn't get year-round tablets.
Anybody else?
Yeah, I'm just curious. As you know, we don't have ragweed, at least on this side of the mountains. But do you have patients on both, and do you overlap? Because the times would require that. Do you overlap the two tablets?
The FDA recommends against doing that. They may change that at some point, but there are clearly patients that need both because they're allergic to both, and they do overlap. If you treat through the end of the grass pollen season, if you want to start for ragweed in the Northeast, you have to overlap for a bit of time. And I have done that several times, and the way I chose to dose it was give the grass in the morning and the ragweed in the evening, so like 12 hours apart. But at the college meeting last fall, they presented the result of a controlled trial where they intentionally did dose both. And they got closer and closer in time of administration as well. You can imagine if I told patients to use it 12 hours apart, they're probably going to pop one, and 15 minutes later they'll pop the other one in the morning. The bottom line is that controlled trial, looking at co-administration, showed that it was safe. And maybe the FDA will change their language in the label someday, but I don't know. But they're against it, co-dosing, because they don't know if risk of one goes up from treatment with the other, or vice versa. It just hasn't been studied real well.
Have they done any subgroup analyses of the patients who have coexisting asthma, see if they have any reduction in asthma symptoms or asthma medication? It's kind of the hypothesis of the one airway. If you improve your upper airway, you may impact, get good benefit in your lower airway also.
There's plenty of trials in Europe that were done to show that asthma symptoms are helped. When I've approached the companies here, they're very careful about looking at that because they don't want to appear to have a claim in their label for treating asthma. So they seem to be almost reluctant to do those analyses. They did the analysis for adverse events that I showed you earlier on for asthma, but they don't seem to want to venture into looking at subgroup analyses that might suggest that they have benefit in asthma. I think they want to do trials with that as a primary outcome, but I think they're reluctant to look at it as a secondary outcome for fear that they might be promoting it for asthma. And I don't think they want to do that. There's a real interesting trial that should read out in the next year or two done in Europe called the GAP trial, Grass Allergy Prevention trial, I think. They took really small kids with who were at risk of developing asthma and treated them for, I think it was 3 years, with grass tablet under the tongue or placebo. And the readout of that is asthma development, I think at the age of 4 or 5. So it's going to be able to hopefully show if early treatment actually can prevent asthma. But the Europeans, they seem to be more free to venture into those sub-analyses in their trials. They have shown that asthma symptoms are reduced with sublingual therapy as well. And that may be even more relevant when dust mite tablets come out. I think they're right before the FDA right now. The pivotal trials are done with them. They showed benefit, and that dust mite might even be more relevant to asthma than the pollens are.
What are your thoughts on combining skit and slit, maybe at least for the first year?
Good question. If you read the label, what the FDA says, don't do it.
Right.
They said that you don't know if one will raise the risk of the other or not. And they only say that not because it does raise the risk, it's because they don't know if it raises the risk, because it hasn't been studied. In your practice, you could do what you want and what you feel is best for your patient, but right now there's no data to guide you.
Does anyone have any anecdotes on that? No?
Well, it's funny because on some insurances you have to get a PA to get grass tech covered. I've had a couple that they say, well, they have to try skit first. I'm like, is it that much less expensive? So it's kind of interesting the different takes that And I'm, pretty confident they wouldn't approve both, but obviously somebody could pay out of pocket for both.
Some of them are requiring a trial, failing a trial with an antihistamine or an intranasal steroid spray.
Yeah.
But how can you prove anymore that people took those? Those are over-the-counter
No, exactly.
medications. You might have to produce a receipt.
In fact, that's a subset of patients who end up sort of on IT because they won't do anything else.
Yeah.
It's fish lick and
It's just clinical empiricism, but those of us who've been practicing a long time, when you put people on subcutaneous and you've had them on for a couple of years, I've told people with no scientific credibility whatsoever, you're going to get like 70 to 90% improvement in your symptoms. And I just made that up. But you clearly see people who basically become asymptomatic. And I'm amazed when I look at figures that 30% is good. And either, I'm overestimating what I can accomplish with subcutaneous, or patients reporting is open practice is not reliable. I just don't know how to square 30% improvement with what you see in the real world of people who come in and say, I don't take medicine anymore, I don't have any symptoms, I lived through the grass season, it's great, I don't ever want to stop this kind of treatment.
And we've all had patients like that, right?
Yeah.
I've had them, same thing. But the bottom line is, the numbers you're looking at come from really highly controlled trials. SCIT has been around for, 100 years now or so? And never had to go through these pivotal trials. If it would, I'd be really curious to see what it would produce. I think my guess is it would produce more, similar to what you're saying, but just hasn't undergone such controlled clinical trials as the tablets have. We've learned a lot from the tablets, and maybe it's a way to learn more about SCIT moving forward too.
Well, thanks again. I know you got a plane to catch.
You're welcome. Thank you all for coming.
We had a good turnout.
I know. Check it out. I will.
You wouldn't show up by yourself. You know who's paying you dinner. You only get a free meal.
Good, how are you? Congratulations on your marriage.
Thank you. It's I heard for the Northwest Allergy Forum.
Yeah, read my mind.
Hey, nice to see you. You heading out right now, or?
Yeah.
Oh, okay.
Gotta get the watch.
Alaska Airlines.
Oh, okay. To DC, you're heading to Bell?
Lachelle, Mark Lachelle.
Michelle.
Yeah,
Okay.
he's in charge of it.
All right.
He's the lucky one this year.
All right. Perfect. I will reach out to him.
Yeah.
Great meeting.
We're all helping him, but he's
Really good for the
Okay, and if you give me the contact for the
Wind a little bit.
and the
yeah, and actually, Nicole Eisenmeter would be the main contact for that sort of thing.
and she's with Group Health.
No, so she's with us with asthma, but she's our main person who does all the administrative stuff for the Washington State.
Perfect. Thank you.
You're welcome.
I appreciate
Yeah,
that.
of course.
All right.
I've got to be careful not to let this go to the wrong office.
Okay, where do you want this to go? This one's full.
The 7th floor, I'm pretty sure is where.
All this stuff is done like that?
Yeah.
Chuck's here, huh? He must be out.
Oh, okay. Got all our things.
I get to get my little booklet.
Hmm?
I get to get my little booklet.
Are you going to the 7th floor now?
I am, yeah.
Okay.
So I can take that up for you if you like.
Perfect. Do you have the printout of this?
Yeah.
Okay.
Because I just ordered that little booklet.